This part is about intubating laryngeal mask airway, or the fast track. Although the laryngeal mask airway can provide satisfactory oxygenation and ventilation for most surgical patients under general anesthesia, it's clear that tracheal intubation continues to be necessary for emergency intubation and some operative procedures. While it is possible to perform tracheal intubation blindly through the classic laryngeal mask airway, the success rate is less than optimal. Several modifications of the intubating technique through the classic LMA have been suggested to improve the success rate. However, the results are inconsistent. This is what prompted the invention and the production of the intubating laryngeal mask airway, or the fast track. The design of the mask of the intubating laryngeal mask airway itself conforms more to the anatomy of the pharynx. The package, it comes in a package, and the package contains three things: the laryngeal mask airway itself, and an accompanying reinforced tube, and a stabilizing rod. The intubating laryngeal mask airway has a metal shaft that's curved to conform with the pharyngeal anatomy. This curvature brings the tube, when it emerges from the opening here, anteriorly, so that it is more easily directed towards the glottis. It also has a metal handle. You can use the metal handle for insertion with a single hand, taking the mask out, or mask adjustment once the mask is in the mouth. The opening of the shaft is wide enough to accommodate a size 8 millimeter internal diameter endotracheal tube when you use a mask of size 5. The mask also has an epiglottis elevating par. This par helps lift the epiglottis away from the direction of the tube, facilitating the tube insertion into the glottis. This is the endotracheal tube that comes in the same package with the fast track. It's different from the regular PVC endotracheal tube in that it is wire reinforced. It has a softer tip, and it has a line of a mark here, a black mark here. This mark denotes that the tip of the tube is emerging from the opening of the mask once it is in place. It's recommended to use this tube for better success rate when we intubate through the fast track. The third component of the package is a stabilizing rod. This rod helps to stabilize the endotracheal tube in place once it is in the trachea, and allow us taking the laryngeal mask out while keeping the tracheal tube in place. Now I'm going to show you a demonstration of the way of fast track insertion. The intubating laryngeal mask should be held this way. The patient head is in the neutral position. You hold the tongue and the lower jaw with your thumb and the rest of the fingers. Lift it up, and with a rotatory movement introduce the mask until it sits in the right spot. Now you can attach your breathing circuit into the mask and provide ventilation for the patient. As you can see, the lungs are both moving, which indicate that you are successfully ventilating your patient. However, You need sometimes to pass an intratracheal tube for this particular type of patient. Example, patients with full stomachs, like cesarean section, intestinal obstruction, in which you had a difficulty visualization, and a patient who is going to remain intubated in the ICU for 3 or 4 days. You need to pass a definitive airway. This is the recommended intratracheal tube that came with the laryngeal mask in the same package, and it has a black line on the back. You try keeping this black line facing you while introducing the tube. Now I'm going to introduce the tube through the opening, and at this point where you have a black mark, this denotes the emergence of the tip of the tube through the mask opening. Now is the time to lift a little bit with your left hand the handle of the mask and further introduce the tube to find its way into the trachea. Now you can inflate the cuff, verify the position of the tube by hooking up your circuit to it and finding internal CO2 waves. And now you made sure that the position of the tube is intratracheal. You can take the connector of the tube out, and it's recommended to keep it with the breathing circuit so that it doesn't get lost. And then with your left hand you stabilize the intratracheal tube. You deflate the cuff of the laryngeal mask airway, and you don't apply force pushing the tube in. You just stabilize the tube in position while trying to take the mask away. Once the mask comes out, you can hook up again your circuit and make sure that your tube is still in. This method of intubation is recommended in situations in which you don't have a fiber optic available, or you have a contraindication or difficulty using the fiber optic, like in bloody mouth situation or traumas or etc. It has a high success rate of passing the tube blindly into the trachea. The success rate is higher than 90%. It can be used for undervision, but you don't have to use it. It's one of the 2 masks that were designed initially with the idea of intubation through the mask. The second device I'm going to talk about is the combi tube. The combi tube is an easily inserted double lumen, double balloon supraglottic airway device. The major indication of the combi tube is as a backup device for airway management. It's an excellent option for rescue ventilation in both the in and out of the hospital emergencies and in situations of difficult intubation and ventilation. It's useful especially in patients with massive airway bleeding or limited access to the airway, and in patients in whom neck movement is contraindicated. The tube comes in 2 sizes, the adult sizes and the small adult size. As you can see, it's a double lumen tube. It has 2 lumens, lumen 1 and lumen 2. And it has 2 black markings over here and 2 balloons, a pharyngeal balloon, the bigger one, and a smaller distal balloon. It has pharyngeal openings through which you can ventilate your patient. And one of the tubes, which is the esophageal tube, ends blindly, as you can see. The other tube has an opening at the end. and there is a partition between the two tubes all through. It has two pilot balloons, each one leading to its corresponding cuff. The tube is disposable. Now, this tube is inserted blindly in emergency situation to establish ventilation, and most of the time it finds its way to the esophagus. It can be placed in the trachea, but this is rare. This is a rare event. It happens in less than 5% of the cases, because the curve of the tube make it more likely to go into the esophagus. Now, it's possible to ventilate the patient. The advantage of this tube is that it's possible to ventilate the patient regardless of the end position of the tube. So the tube is, number one, easily inserted. Number two, you don't have to have a specific placement for a tube for successful ventilation, which make it a good choice in case you are desperate to establish ventilation, or in case other airway management devices fail to provide adequate ventilation. That after positioning of the tube, you should inflate the cuff, the proximal cuff, which is the pharyngeal cuff. This prevents air from leaking back and not going ahead to the lungs. After inflating this pharyngeal cuff, you inflate the distal cuff with 8 to 12 ml cc's of air, and you will be able to ventilate according to the position of the tube. If the tube is positioned in the esophagus, which is a more common scenario, you will be able to ventilate through this pharyngeal perforation, and you attach your breathing circuit over here to the blue tube. If the tube accidentally is in the trachea, you will find this out if you attach your breathing circuit over in the tracheal tube over here and find internal CO2 waves. So it can be successfully used for ventilation regardless of the final position of the tube, whether it is esophageal or tracheal. And I'm going to demonstrate to you the placement. The patient head in the neutral position. This is the way the tube should be held. You hold the mouth and you hold the tongue and the lower jaw, lift them up, introduce the tube in the middle line, and advance it slowly until it is in the right spot. And as you see, it goes very smoothly. Now you start by inflating the pharyngeal cuff, and usually this is denoted on the pilot balloon which one is the bigger leads to which cuff. This one, it's straightened over it, maybe you cannot see because it's blue, 100 ml. So this leads to the bigger balloon, which is the pharyngeal balloon. This is to prevent accidental inflation of large volumes into the esophageal balloon. Now I'm going to inflate the pharyngeal cuff. And I said in most of the situation, the tube goes to the esophagus. And I'm going to test ventilation through hooking up my breathing circuit into the esophageal lumen first. If I am successful, then I'll find end-tidal CO2 waves, I'll find lung movements, and the ventilation occurs through the pharyngeal perforations that I just showed you. What happens if accidentally the tube went to the trachea? Then you have to inflate the distal cuff with 8 to 12 millimeters of air. And then remember, this tube is not blind. This tube has an opening at the end. So if you attach your breathing circuit and the tracheal tube and try to ventilate, you will be verifying the position by enter the C2 waves and finding the chest rise and fall with your ventilation. The problem of the combi tube is that it's an excellent way of securing ventilation once you have a trauma here in this area, or bloody airway, or situations which you cannot use other devices. But exchanging it is a little bit more tricky. It needs a couple of manipulations to get to the definitive airway. Some people even advocate leaving it in place until the edema subsides. A modification of this tube, a recent modification of the combi tube, actually has came to the market last year. It's the laryngeal tube, and the laryngeal tube, as I will just show you, carries the same principle of the combi tube with few differences, which are good differences actually. Again, it carries the same principles of blind insertion and successful use during emergency airway establishment. However, it doesn't have two pilot balloons. You can inflate actually the pharyngeal balloon, both the pharyngeal balloon and the distal cuff, pharyngeal cuff and distal cuff, with only a single injection of air. So if I inject air through the here, it will inflate both cuffs, which is a good way of avoiding the confusion how much air should be injected in each one and which one leads to which cuff. The second big advantage actually is this laryngeal tube doesn't protrude into the esophagus. It stops at the hypopharynx, where the esophagus meets the lower esophageal, the lower pharyngeal sphincter. So it avoids injury of the pharynx. Again, it's intended for blind insertion, just like the combi tube, and it provides ventilation through those pharyngeal perforations over here. It doesn't go to the trachea and it doesn't go to the esophagus, but it's a supralaryngeal airway device carrying some of the principles of the combi tube, and with a little bit smaller size than the combi tube in order to avoid airway trauma. What I'm going to talk about now is the AirQ laryngeal airway. There are two masks, or laryngeal masks, developed actually for intubation, to be used as channels through which you can intubate patients. The idea is that you can use the masks for ventilation, and you can intubate through those masks. Not all laryngeal masks can be used as conduits for intubation, but there are two principal masks that we can use. Number one, the one that I showed earlier, which is the fast track, or the intubating laryngeal mask airway. And the second one is this laryngeal airway. It's not a laryngeal mask, but it's a laryngeal airway. It's actually serves the same purpose, which is can be used alone for ventilation, and it can be used for passing an endotracheal tube. The difference between this device and intubating laryngeal mask airway is that this device doesn't have much of a success of blindly intubation through them. You can intubate with an optical stellate or a fiber optic tube through this shaft. It's easily inserted, so it's useful in critical situations, and it has a better success rate of blind intubation than the classic laryngeal mask airway. I'm going to show you how to introduce the AirQ. The AirQ is simple. It can be introduced the same way as the classic LMA. Again, you hold the patient lower jaw and introduce it. However, it's easily inserted than the classic LMA because of the way it is shaped actually. And after inserting it, you can either hook up your circuit over there and try to ventilate with the mask, and it provides a good way of ventilation. However, you can also intubate through the mask by passing in the endotracheal tube that goes straight into the place, and you can hook up your circuit over there. And as you can see, the lungs are both moving. So this one was a successful blind insertion through the air cube. The last thing that you will need to know is that there is a stylet that comes, and it can hold the tube in place while you take the mask out. And this will provide a final mask in while taking the LMA out solution. The other way, actually, of doing it is that after introduction of the air cue and ventilation, to make sure that you are able to ventilate the patient with the air cue, you can just remove this cap and introduce your fiber optic or optical stylet with the tube loaded over it, and go through the shaft of the mask, try to identify the position of the larynx, and railroad your tube after you enter the glottic opening. So this is a second way of intubating the patient through laryngeal. This is the way the tube exits through the opening in the mask and then enters through the glottic opening into the trachea, after which you can ventilate through your endotracheal tube. The biggest criticism with the laryngeal mask airway is that it includes both the laryngeal opening and as well as the esophageal opening within its rim. This makes the patient vulnerable to aspirate any regurgitated material that comes through the esophagus and finds its way to the trachea without you even noticing it, because it's hidden in there. Sometimes when it is active act of vomiting, you notice some of the material coming out through the shaft of the LMA. But if it is just passive regurgitation and aspiration, can happen without you even noticing it, apart from a decrease in the saturation. This is the biggest criticism for the laryngeal mask airway. The other limitation of the laryngeal mask airway is that some people find it difficult to use intermittent positive pressure ventilation because this can lead to stomach distension and regurgitation. Those problems were addressed and purified a more advanced form of laryngeal mask, which is the ProSeal laryngeal mask airway. The ProSeal laryngeal mask airway was invented to incorporate a gastric suctioning channel through it, so that it provides better isolation of the trachea from the gastric contents. It's not as effective in this isolation as an endotracheal tube, which again is not 100% effective, but it's a better, step towards isolation than the classic LMA. And a newer version of the ProSeal LMA is the LMA Supreme. Here's the LMA Supreme. It's a disposable form of the LMA that incorporates a drainage channel behind the ventilatory shaft over here. So your breathing circuit, after positioning the mask, will be attached here, and this channel, this drainage channel, runs all the way and opens at the tip of the masks. This tip of the mask is designed to anatomically be placed at the point where the esophagus meets the pharynx, so that the drainage channel constitute a route, an extension to the esophagus, routing material away from the ventilatory limb in case any regurgitation happens. On the other hand, you can pass a small gastric suction tube through this opening and it emerges from here and goes through the esophagus to the stomach. As a matter of fact, this is a way of knowing the proper positioning of this laryngeal mask. If the tube comes out smoothly and goes to the stomach, and you are able to suction gastric contents, then you are in the right spot. The other advantage of this mask, apart from providing better isolation and avoiding the biggest criticism of laryngeal mask airway, which is aspiration, is that it can be used actually for positive pressure ventilation. Since if you apply positive pressure ventilation here, in case even any air leaks into the stomach, it's going to be drained back through this drainage channel. It has also a tab here where you can know exactly the depth of the position and keep it right there in order to get the best out of this device. As opposed to the ProSeal laryngeal mask airway, this device has a more or less rigid curvature here that facilitates its insertion through the pharynx. And one of the criticism of the ProSeal is that it was flimsy, more flimsy and pliable, and you couldn't pass it easily. You should be holding it tight. But with this rigid structure, you find it easier to insert it actually than the ProSeal. And again, it's following the same principles of LMA insertion. It's again introduced in the middle line and advance it until it stops right there. Now is the time to inflate the cuff, to seat the laryngeal mask, and then provide ventilation through your breathing circuit. You can pass a stomach tube through this opening that will emerge through the tip and continue through the esophagus to the stomach, and you can apply suction to this. This device is a better backup device in situations of difficult intubation for an emergency C-sections, when you have an extreme emergency and you have to induce general anesthesia for a cesarean section and you don't have an epidural catheter in place. You induce general anesthesia and you find a difficult visualization. Difficult mask ventilation, then I think this device is much better than the classic LMA in the terms that it provides better isolation, since all protrusions should be considered as having full stomach. You will be able to apply ventilation and to apply gastric suction through this channel. With many airway devices becoming available to us for clinical use, and with the adherence to the ASA difficult airway algorithm, we find less and less cases every day that really need an emergency airway establishment in the form of cricothyrotomy. The incidence has declined dramatically since the proper evaluation of the airway and proper management, allowing for awake intubation options, as well as the presence of and availability of many airway devices you can manage the airway with. Finally, in a situation that the use of cricothyrotomy has been declining. Nevertheless, in a certain minor percentage of patients, it's the one way to emergently establish the airway, and it's the resort that you have to take, otherwise you will lose the patient. I am going to demonstrate to you simply on a mannequin how to do these simple procedures, and hopefully you can get the skill through airway workshops and other simulation sessions to practice this. You don't have to be an expertise in it. You can have always somebody from surgery or ENT or by your side if you are thinking that this might be the last resort for the safety of the patient. As we said, cricothyrotomy should be the last resort to establish an airway. However, should be a quick procedure, an emergency procedure in case all other measures fail. First, you identify the cricothyroid membrane by palpating the cricoid cartilage and the thyroid cartilage. Palpate the membrane in between, and with a short handled scalpel make a transverse incision through the membrane. Get a needle or a caster, introduce it. Usually the needle or the caster are with the kit, cricothyroidum kit, in the same kit. You introduce it through the membrane until it perforates the membrane. You will be able to identify that you are in the trachea by air aspiration. Afterwards, introduce a guide wire that's also present in the kit through the caster or the needle. Next step is to take the needle out or your caster out, and there is a dilator in the kit here. You introduce the dilator through the Airway caster and introduce the whole assembly through the guide wire. Then advance the whole assembly together. Dilator takes care of dilating the incision. And then the last thing is to take both the dilator as well as the guide wire out and keep the Airway caster in place. There is usually some sort of a gauze with which you can secure your caster in place, and then in a couple of minutes you will be able to establish ventilation in this desperate situation.